Welcome to the webinar, Pressure Injury Prevention and Treatment, Optimizing Healing Through Nutrition and Lean Body Mass. This program is provided by North America Center for Continuing Medical Education, LLC, and is sponsored by an educational grant from Abbott Nutrition. I am Mary Litchford, and I'm going to be your presenter today. I have worked in the area of nutrition and nutrition in wounds for many, many years in both acute care as well as post-acute care settings. I've also worked with family members that developed pressure injuries in an acute care setting and also in a home care setting. So I've worked on both sides as both the professional as well as the caregiver. Today we're going to talk about the importance of nutrition and the importance of retaining lean body mass to optimize healing. I am president of Case Software and Books, and these are my disclosures. I work as a consultant for a couple of industries, work as a Speakers Bureau representative for Abbott as well as Nestle, and I'm currently president of the National Pressure Ulcer Advisory Panel. My company, Case Software and Books, owns this presentation and all rights are reserved. So let's talk about our learning objectives. I like to call these points to ponder. Today I'm going to talk about clinical outcomes and risk for patients who are malnourished or who have low lean body mass. We're going to review evidence-based guidelines supporting nutrition intervention as part of pressure injury prevention and treatment. We're going to discuss the cost of oral nutritional supplementation compared to the cost of pressure injury treatment. We'll examine the role of nutrition screening, assessment, and intervention as key components of a healthcare team's approach to pressure injury prevention and treatment. And then lastly, employ a healthcare team approach to optimize nutritional management to prevent the development of pressure injury and to manage existing pressure injuries. I want you to think about what you learned in elementary school about malnutrition. Maybe you heard it from your parents that you needed to clean your plate because of starving children in a certain country, or maybe you learned a little bit about it in school. We all have perceptions about what is malnutrition, and we all have a vision of what a malnourished person would look like. If you look at the definitions from the World Health Organization, malnutrition has two ends of the spectrum. One is our underweight, stunted, wasted individual, and the other end of the spectrum are our obese and our overweight adults. And if you look at our statistics, almost 2 billion adults are overweight or obese worldwide, compared to 462 million underweight adults. So overweight and obesity is really the bigger issue, no pun intended there, but it is an issue that is reframing our view of what malnutrition really is. Now, if you look at children, about 52 million children aged 5 and younger are wasted. And of those, 17 million are severely wasted. 155 million children have stunted growth, and about 41 million children are overweight or obese. So our numbers for overweight and obesity are coming very close to our numbers of children that are wasted. About 45% of deaths in children aged 5 and younger are linked to undernutrition. So when we think about our markers of malnutrition, we've got malnutrition in the center, and then we have underweight, wasting, vitamin mineral deficiencies, stunting, so stunting of height, overweight and obesity, and diet-related non-communicable diseases. Now, when you think about this, the vitamin mineral deficiencies can be in our underweight as well as our overweight and obese populations. It results in what we call the triple burden of malnutrition. First of all, we have our undernourished and our malnourished individuals who don't consume enough energy or protein. Then we have our underweight and our overweight or obese individuals who can also have vitamin mineral deficiencies. And then thirdly, the underweight early in life can be predisposed to overweight and non-communicable diseases, such as diabetes and cardiovascular disease. What happens is that an infant that is born at a very low weight can rapidly gain weight early in life, and this can predispose that person to long-term weight excesses. Now, nutrition and health are closely related. This is a quote from the U.S. Dietary Guidelines that about half of all American adults, so that's around 117 million individuals, have one or more preventable chronic diseases, many of which are related to poor eating and physical activity patterns. So let's talk a little bit about some of the myths we have about malnutrition. Think about what you were taught in school. If you are a dietitian or a nutrition professional, you studied malnutrition in school. And one of the myths of malnutrition is that malnutrition is only seen in developing countries and in areas affected by political unrest or natural disasters. Malnutrition is always related to a lack of energy and a lack of protein intake. And malnutrition does not occur in my healthcare setting. Let me challenge you to change your perspective about malnutrition. We see malnutrition in developed countries as well as developing countries. If you're not seeing it, it may be because you're not looking for it. Malnutrition may be related to a lack of energy and a lack of protein, or very poor quality protein in the diet. But it's also related to inflammatory stress. What we see with inflammatory stress is that the body adapts to the stress due to illness, due to injury, and it utilizes nutrients differently, and we'll talk about that in just a few minutes. But inflammatory-related stress is probably the biggest driver of malnutrition in our acute care setting, due to infection, due to injury, due to surgery, etc. Malnutrition is costly, and it is associated with poor clinical outcomes. So what about where you work? Do you have malnutrition? If you look at the data that is out there, the first study is the O'Shea study that's on our slide, that more than 60% of these individuals were at risk for malnutrition. Now, this was a study done in 6 hospital sites in Ireland, and it was a prospective cohort study, and they used the M&A nutrition scores to determine who was at risk for malnutrition, who was malnourished, and who had a normal status. So who were the ones most likely to be malnourished? Well, more common in females, acute admissions, older patients, and those who were widowed or separated, so individuals with social isolation. Dementia, functional dependency, and frailty were other comorbidities, and malnutrition and being at risk for malnutrition compared to normal status was significant. We saw a significant increase in length of stay, new hospitalization, and in-hospital mortality. Now, the second study was done by Kaiser, and Kaiser looked at both hospitals as well as post-acute care. So that would be home care as well as the long-term care skilled nursing type facility. And this study was done in 12 European countries and in hospitals, rehabilitation centers, and nursing homes and community settings. And they found this high rate of risk for malnutrition, particularly in the hospital and in some of our post-acute care settings. The mean age for this population was 82 years of age, and there were over 4,000 participants in that particular study. The next one is a hospital study that was done by Lim in Singapore, and Lim found more than 33% were at risk of or were malnourished, and those individuals were more likely to have a longer length of stay, 7 days compared to 4.5, and they were more likely to be readmitted within 15 days, and their cost of care were much higher. Lim also looked at long-term mortality and found that malnourished patients at 1 year were more likely to die within the year, about 34% compared to 4% of individuals that had normal status. At 2 years, the rate of mortality was over 40% compared to about 6.7% of our well-nourished population. And at 3 years, almost half of those individuals had died compared to about 10% of the well-nourished. And so there was that significant relationship between malnutrition and mortality. The last study that's on there was done in Italy, and in this particular study, almost 300 patients, 72 years and older, were followed by general practitioners in 3 towns in Italy. And they found a risk of about greater than 55% of these people were at risk of or were malnourished, and that the malnourished were at greater risk for developing a major medical complications. That included dementia, pressure injuries, bone fracture, hospital admission, and death. So when we look at malnutrition and risk for pressure injuries, we have a lot of literature that shows a relationship. The Horn study reported low BMI, reduced food intake, and impaired ability to eat independently as risk factors for the development of pressure injuries. Fry reported that malnutrition and/or weight loss correlated with a 4-fold higher risk of development of pressure injuries. A Norway study reported that malnutrition was associated with a higher risk of pressure injuries in acute care, and in this particular population, a BMI of less than 20 and reduced food intake had the strongest associations with increased risk. And then Izakaya in Japan did a home care study. They found that the rate of malnutrition in a population 65 years and older was almost 60% of those that had pressure injuries were malnourished compared to about 33% of the population that did not have pressure injuries. So you can see there's a very strong relationship. Now think about the population that you serve. Not everyone is going to have a pressure injury, and probably not all of them are going to be even at risk for developing a pressure injury due to a severe condition. But anytime, even a person who is well-nourished, who goes into the hospital, may become malnourished as a result of things that happen in the hospital. Many days being NPO, perhaps complications from surgery. So we see malnutrition as inflammatory driven, especially in a critical care setting, so acute care. But we also see these conditions, diabetes. With diabetes, we have impaired glucose tolerance, and that impairs utilization of glucose as well as transport of oxygen and carbon dioxide. So that's going to impair wound healing. Heart failure, atrial fib, myocardial infarction, COPD, much higher energy requirements when respiratory is an issue. Renal insufficiency may impact some food choices, maybe losing a lot of protein through the urine. Anemias, that's also related to renal insufficiency. And then dementia. And so these are conditions that can impair healing that are managed with medical nutrition therapy. Now, when we talk about our characteristics of malnutrition, these are characteristics for adults. There are characteristics for pediatrics, but that's not our topic today. These were published in 2012, and there are 2 degrees of severity. One is non-severe malnutrition. Now, that would be considered undernourished or undernutrition. The second degree is severe malnutrition. Now, malnutrition can be seen in 3 different contexts. In the context of acute injury or illness, and that would be something that has been going on for less than 3 months. So your window of time is going to be less than 90 days. Chronic illness is going to be a condition that has continued for more than 90 days or more than 3 months. And then the last one is social and environmental circumstance. So what does that mean? Well, that's a change in socioeconomic status. Perhaps someone has lost a job, perhaps their home is burned down, perhaps their home has been destroyed by a natural disaster. And so suddenly they become food insecure, and they don't have enough resources to purchase food as well as medicine or perhaps to pay their other bills. Also in this category are individuals that limit food choices based on their food preferences or beliefs. We see a number of individuals that are very fearful of eating certain foods or who have restricted their diets dramatically based on concerns about food sensitivities. So these are the characteristics of adult malnutrition. The first one is insufficient energy intake, and it has 2 benchmarks. One is a percentage of estimated energy requirement. Now think about how food intake records are kept in your healthcare facility. Is it based on percentage consumed, or is it based on percentage of estimated requirement? Most often, it's based on percentage consumed. The amount that's served may or may not be appropriate for a person of that age and of that size. And so you have to look at it a little differently than perhaps we have in the past. The other benchmark is time in the number of days or months. Let me give you an example. For an acute illness, in order to use this characteristic of malnutrition, this would require less than 75% of estimated energy requirement consumed for more than 7 days. 7 days is a long time to be collecting data, especially in an acute care setting. In a post-acute care setting, it might be reasonable to use that, but you do have to have a number of days. If you look at severe malnutrition, because that was the non-severe, it is 50% or less for more than 5 days. So again, think about your length of stay in terms of using this particular characteristic. The second one is interpretation of weight loss, and this is a percentage of weight loss using 2 data points. So we have a historic date for weight. Maybe it was taken in a different setting, but say your admission weight, and then your weight several days later, maybe 5, 7 days later. Then there's also a time period, a number of days or months. For example, with non-severe malnutrition, interpretation of weight loss would be 1 to 2% in a week, so again 7 days, versus our severe malnutrition, more than 1 to 2% weight loss in a week. So again, you have those 2 benchmarks, but you've got to have the data and at least that many days. The next 3 are changes in body composition, and these are determined using nutrition-focused physical assessment. Loss of body fat, loss of muscle mass are the 2 most commonly ones done, and this is done doing a hands-on assessment of different areas of the body where we do see loss of body fat as well as loss of muscle mass. Now the 5th one is accumulation of fluid. Accumulation of fluid is not always a characteristic of malnutrition. You see accumulation of fluid in many individuals in post-acute care. it's related to heart function. It's not really related to malnutrition. But we know that when serum albumin levels get very low, that the body will retain more fluid. And so it may be a marker of malnutrition. So you want to work with your other team members as you interpret that accumulation of fluid. And then grip strength is only used in our severe malnutrition category. That would be using a dynamometer. A dynamometer is a tool that measures your grip in pounds or kilograms of pressure. And it gives you, as well as the patient or resident, an objective measure of what their strength is. Now, if you have arthritis in your hands, or perhaps you have had some type of a neurological event and you don't have strength in one hand, then this particular characteristic is not useful for that particular patient. Now, I've mentioned inflammation and inflammatory stress, and I want to just review what happens in the body with inflammatory stress that drives malnutrition. We have inflammation, and that can be from an infection or an injury. It could be from a chronic disease, so it could be acute or it could be chronic. Either way, we have basically two responses, and there's a cascade of responses, and I only have a few of the components on this slide. The first is a gene expression, and it's the NFKB, that stands for nuclear factor kappa beta gene expression, that tells the cells of the body to make cytokines. Cytokines are synthesized in response to inflammation, and so something bad is going on, because normally you wouldn't have these cytokine levels present in the body. The immune response is a second component, and so you have some immune cells that are ready to be deployed, your T cells or B cells, but they don't live very long, less than 24 hours. And so you've got to synthesize more of these. Well, your immune response also triggers cytokine release. Now, cytokines can be released from most cells in the body. Your white blood cells are your most common source of cytokine release. The cytokines affect every organ system in the body. One is decreasing appetite. You're not hungry. It also affects your capacity to think very clearly. It slows down digestion, can contribute to a depressed immunity and anemia. There's a long list of effects of cytokines. Well, when you are decreasing your appetite and you need to mobilize nutrients to make immune cells as well as cytokines, then where are those sources of protein and energy coming from? Well, that's when you start losing lean body mass. Now, the cytokines do one other thing, and that is they redirect the liver to make positive acute phase reactants. Those would be C-reactive protein, it would be ferritin, fibrinogen, or just a few, and redirect the liver to make less albumin, prealbumin, retinol-binding protein, and transferrin. And so with inflammatory stress, you see increases in CRP and decreases in albumin and prealbumin as a result of the cytokines. Now, there's one other thing that happens in inflammatory stress with lean body mass. Every day, your body utilizes between 200 to 300 grams of protein a day. Yes, you heard me correctly, 200 to 300 grams of protein per day. Well, you don't eat that much, do you? Probably not. You would eat about a third of that amount, and so the other two-thirds comes from skeletal body mass. So every day that you consume protein, the body breaks that protein down into amino acids. It makes the dispensable amino acids, and so hopefully you've got plenty of those indispensable amino acids, the ones the body can't make, and the body also contributes some of the lean mass reserves from skeletal muscle tissue. Once you get to a low level of skeletal muscle, the body starts drawing upon the visceral muscle, and so that's going to be from your organs such as your heart. Well, the body takes all those proteins, breaks them down into amino acids, and then reorganizes those amino acids based on what tissues are required for the body for that day, and it might be for wound healing. And at the end of the day, you want to put every molecule of protein back into lean body mass that you took out. And if you're eating a sufficient amount of protein and a sufficient level of energy, then that happens because you oxidize very little of it, and so that's how your body maintains itself. Well, in inflammatory stress, the body doesn't function normally, and so you have this impaired utilization of amino acids. You have an increased nutrient requirement as well as a decreased efficiency. So you oxidize a lot more of the protein for energy, and you have a lot more waste. And so your amino acids are not being utilized as they would be in an efficient manner, and that contributes to that slow wound healing that we see in many of the individuals that we serve. Well, that's just an introduction about malnutrition. Let's talk about the clinical practice guideline. The National Pressure Ulcer Advisory Panel, the European Pressure Ulcer Advisory Panel, and the Pan-Pacific Injury Alliance have worked together to develop a guideline, and these were published in 2014. The group is working on the 2019 version as well, just as we speak, and I am one of the representatives from NPUAP. In the guideline are nutrition recommendations, and they include nutrition screening, nutrition assessment, care planning, energy intake, protein intake, hydration, and vitamins and minerals. And so we're going to look at the guideline and see what the nutrition recommendations are. The first recommendation deals with nutrition screening. Do you do nutrition screening for all of your new admissions? Certainly in some settings, that is the policy. But the recommendation is to screen the nutritional status of each individual at risk of or with a pressure injury. At admission to the healthcare setting with each significant change of clinical condition and when progress towards pressure injury closure is not observed. Now, what kind of screening tools should you use? Well, they need to be valid, they need to be reliable to determine nutritional risk, and for individuals that are screened to be at risk of malnutrition and individuals with an existing pressure injury, that person needs to be referred to the registered dietitian nutritionist or an interprofessional nutrition team member. And that is a term that is used outside of the United States, and that would be for a comprehensive nutrition assessment. So let's talk about what's the difference between a nutrition screening tool versus a nutrition assessment. A screening tool is quick and easy. It can be completed by anybody on the healthcare team. It can be completed by the patient or the family member. It's highly sensitive and has a high specificity, validated. It is completed on all new admissions, and most of the tools have a weighted score so that based on your answer to the questions, you would get a numerical score, and then that score is summed up. The sum of the scores is associated with degrees of nutritional well-being. Now, ideally, that total risk score is populated into your electronic health record in a section that is viewed by key medical providers. Now, a nutrition assessment is a little bit different in that it is a comprehensive nutrition assessment that includes all of the components of the nutrition care process, and typically it is done by a registered dietitian nutritionist. So these are the tools that are included in the current version of the current edition of the clinical practice guideline, and these are the links that lead you to those: the mini nutrition assessment, the malnutrition screening tool, the Malnutrition Universal Screening Tool, the Short Nutrition Assessment Questionnaire, and the SGA, which is the Subjective Global Assessment. So why is screening so important? Well, screening is important because malnutrition contributes to the cost of treating pressure injuries. Bank did a study in Australia in 2010 where she estimated the cost of treating pressure injuries that was attributable to malnutrition, and about a third of the costs were attributed to malnutrition. She only looked at the cost associated with increased length of stay associated with pressure injuries. Consider all the other costs involved in treating pressure injuries. And then the other study was from Germany that looked at the relationship between malnutrition parameters and pressure injuries. And this was in 22 hospitals and 29 skilled nursing facilities. They looked at over 4,000 patients. They assessed malnutrition looking at body mass index of less than 18.5, a low nutritional intake, and undesirable weight loss. And what they found was a significant relationship for pressure injuries in both settings, hospital as well as skilled nursing, for individuals that had undesirable weight loss, low nutritional intake, and low BMI. Well, let's get back to our nutrition recommendations. Nutrition assessment. The comprehensive nutritional assessment that is outlined in some of the documents from the Academy of Nutrition and Dietetics has a more in-depth nutrition assessment than is in the guideline, but this is what's in the guideline. To assess weight status of each individual, to determine weight history, then identify significant weight loss, and there are specific parameters, and these are consistent with our characteristics of malnutrition. To assess an individual's ability to eat independently. And thirdly, to assess the adequacy of total nutrient intake from food, fluid, oral supplements, and enteral or parenteral feeds. Now let me talk about the word fluid. Fluid can be water or it could be vegetable oil. There is an RDA for water. There is not an RDA for fluid. But the Academy of Nutrition and Dietetics and the Clinical Practice Guideline use the word fluid. I prefer the word water. Let's get back to our topic of care planning as our next component, and that is to develop an individualized care plan for individuals with or at risk of a pressure injury. That we don't want just a one-size-fits-all, everybody gets a supplement at 2 o'clock or whatever, and you have one choice of flavor. We want an individualized care plan. And we want to also follow relevant evidence-based guidelines on nutrition and hydration for individuals who exhibit nutritional risk and who are at risk of pressure injuries or have an existing pressure injury. So think about that list of conditions that I had in an earlier slide of very common medical problems that impair the healing of wounds. And so, such as diabetes, such as heart disease, we see that these diseases have evidence-based guidelines. And so we always want to look at those in the context of meeting all the care needs of these individuals. Let's transition to our energy intake. We want to provide individualized energy intake based on the underlying medical condition and level of activity. The recommendation is to provide 30 to 35 calories per kilo of actual body weight for individuals at risk of a pressure injury and malnutrition. The third recommendation is to provide 30 to 35 calories per kilo of body weight, and that's actual body weight, for an adult with a pressure injury who are assessed as being at risk of malnutrition. So we have those same levels. So what do you do with your patient who is obese? Well, the recommendation is to adjust the energy intake based on weight change. So the individual who's lost weight, they may need more than 35 calories per kilo, or the individual with obesity who may need less than that. And adults who are underweight or who have had significant unintended weight loss may need an additional energy intake. The fifth one is to revise and modify or liberalize dietary restrictions when limitations result in decreased food and fluid, should be water, intake. These adjustments should be made in consultation with medical professional and managed by an RDN whenever possible. We can't always liberalize all of our diets, but if it is limiting food intake, that's something that we want to look at as part of the medical team to discuss. In terms of meeting energy requirements, offer fortified foods and/or high-calorie, high-protein oral nutritional supplements between meals if nutritional requirements cannot be achieved by dietary intake. We don't want people to drink supplements at meals. We'd like for them to eat food. Now, you can fortify foods at meals, and you want to be sure that that is a tasty product that the person will accept. Recommendation 7 is to consider enteral or parenteral nutritional support when oral intake is inadequate, and this must be consistent with the individual's goals. Now, before we talk about protein, let me mention this relationship between energy intake and nitrogen balance. When you have a very low energy intake and you're in negative energy balance, your requirement for nitrogen and for protein is much higher because you are using the protein for energy. And so as you improve in resolving that negative energy balance, then your protein requirement falls. Now, we know in our critical care population that we often will give them a hypocaloric diet with a very high protein intake. But remember that relationship between energy intake and nitrogen balance. So energy is very, very important. So let's talk about protein. We want to provide an adequate amount of protein for positive nitrogen balance for adults assessed to be at risk of a pressure injury. The recommendation is to offer 1.25 to 1.5 grams of protein per kilo of body weight, and that's actual body weight, daily for adults at risk of a pressure injury and malnutrition when compatible with goals of care and assess as condition changes. Thirdly, provide adequate protein for positive nitrogen balance for adults with a pressure injury. Now, all protein sources are not nutritionally equal. They're what we call complete protein. And complete protein means that you have the right combination of all of the amino acids that the body cannot make, and those are called indispensable amino acids or essential amino acids. And animal products and some of our plant proteins contain the right combination of all those amino acids. And so you want the person to receive high quality, high biological value protein. There are incomplete protein products on the market. Many of our luncheon meats and hot dogs can have fillers in them. Some of them are better quality than others, but our ground meat products can have a lot of fillers in them as well. Products like pork skins, you may have a bag of pork skins that says this contains 40 grams of protein, but because it doesn't contain one of the indispensable amino acids, tryptophan, it's not a complete source of protein. So think back to what I was talking about how the body uses 200 to 300 grams of protein every day. The body breaks down all the protein into individual amino acids, and you've got to have a certain combination of amino acids to build body components, to synthesize tissue, to rebuild muscle mass. And if you don't have all the pieces of the puzzle, then the body can't use all these extra pieces to make what it needs. And so serving complete sources of protein is very, very important. There's one other thing that's come out in the literature, and that's the importance of one of the indispensable amino acids, leucine. Leucine is found in animal products. It's found in really all of our protein sources, and yet much higher in animal products than our plant products. If you look at the level of leucine compared to other complete sources of protein, I just pull these off of the USDA website for different nutritional supplements, you'll see that the leucine content is much higher in whey protein. Now, the reason why this is important is that you've got to have a certain amount of leucine at every meal to trigger tissue synthesis and to rebuild that lean body mass that you've lost and to rebuild those tissues that have been injured through pressure. And so having a diet sufficient in leucine is very important. If you have a wound that is stalling, it may be that you don't have a high enough level of leucine at each meal in order to trigger optimal tissue synthesis. The next protein recommendation is to offer 1.25 to 1.5 grams of protein, and this is high-quality protein, per kilo of actual body weight daily for adults with existing pressure injury and who are assessed to be at risk of malnutrition when it's compatible with goals of care, and we want to reassess as the condition changes. The next recommendation is to offer high-calorie, high-protein nutritional supplements in addition to the usual diet to adults with nutritional risk and pressure injury risk if nutritional requirements cannot be achieved by dietary intake. So our emphasis always on food first, but we are delighted that we have some additional resources that we can use, and these include our high-calorie, high-protein nutritional supplements. The sixth recommendation for protein intake is to assess renal function to ensure that high levels of protein are appropriate for the individual. Individuals that have impaired liver function probably would merit your review as well. The seventh recommendation is to supplement with high-protein arginine, which is a conditionally indispensable amino acid. That means the body can manufacture it, but under certain circumstances, such as high inflammatory stress, the requirements are higher. And then also micronutrients for adults with pressure injury, either a category or a stage 3 or 4, or multiple pressure injuries, when nutritional requirements cannot be met with traditional high-calorie and protein supplements. Now, this was based on a study that compared two different nutritional supplements, and I've got them. This is Cedra's study. The comparison of the protein level, the protein was the same. The arginine, the zinc, the copper, the vitamin C, and vitamin E were different, as you can see. And the results showed that approximately 70% of the intervention group had more than a 40% reduction in pressure injury size compared with about 54% reduction in the control group. The efficacy of these nutrients in wound healing is most likely synergistic because there's really no evidence to support an independent effect when given alone. This nutritional intervention may help when added to an optimized local wound care for the treatment of pressure injuries in malnourished patients. Let's move on to hydration. Want to provide and encourage adequate daily fluid, I like the word water, intake for hydration for the individual assessed to be at risk of or with a pressure injury that must be consistent with the individual's comorbid conditions and goals. There are some individuals where we do have to restrict fluid, but not very many. And so we want to be sure that they're getting adequate hydration. Now remember that 80% of your hydration requirements are met through beverages, but the other 20% comes through food. Second is to monitor individuals for signs and symptoms of dehydration. These would include a change in weight, a change in skin turgor, urine output, an increase in serum sodium, and or calculated serum osmolality. The third recommendation is to provide additional fluid or water for individuals with dehydration, elevated temperature, vomiting, profuse sweating, diarrhea, or heavily exudating wounds. So what about vitamins and minerals? Well, we want to encourage and provide individuals assessed to be at risk of pressure injuries to consume a balanced diet. So again, food first. And that includes good sources of vitamins and minerals. We want to provide and encourage an individual assessed to be at risk of a pressure injury to take vitamin mineral supplements when dietary intake is poor or deficiencies are confirmed or suspected. Now, vitamin mineral deficiencies can be confirmed with laboratory test results as well as signs that are identified through nutrition-focused physical assessment. There are very specific signs for different vitamin mineral deficiencies. We also want to provide and encourage an individual with a pressure injury to consume a balanced diet that includes good sources of vitamins and minerals. And fourthly, to provide and encourage an individual with a pressure injury to take vitamin mineral supplements when dietary intake is poor or deficiencies are confirmed or suspected. Those are our recommendations from the global guideline. And so how are we going to implement them? Well, I like to focus on both a collaborative as well as a patient-centered care. And what does that mean? Well, the Institute of Medicine defines patient-centered care as providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. The UK Royal College of General Practitioners defines it as care that is holistic, empowering, and that tailors support according to the individual's priorities and needs. So what about collaborative care? Well, collaborative care entails physicians and all the other providers on the healthcare team using complementary skills, knowledge, and competencies, and working together to provide care to a common group of patients based on trust, respect, and an understanding of each other's knowledge and skills. Now, this involves mutually agreed upon division of roles and responsibilities, and that can vary based on practice responsibilities and healthcare settings and skill sets of those individuals. The relationship must be beneficial for both the patient and acceptable to the physician and the other providers. So what would that look like in terms of patient-centered wound care that's specific to nutrition? Here are just some ideas. Number one would be to screen all admissions for malnutrition using a validated assessment tool. To include the RDN in wound care rounds or meetings. How about agreeing to taste test nutrition supplements? In my years of practice, I have always asked the nurses and the physicians, the therapists, to taste test the different products that we used in the formulary. Because if the staff thought the product tasted terrible, why would we serve it to our residents or our patients? And so we would taste products, and I would bring little samples for them, and it was a real eye-opener to me because some products that I thought were perfectly acceptable were not acceptable to many others. So it gives you a very different perspective and an understanding of the wide choices that are out there in terms of our nutrition supplements. It's very important that we take note of what our patients are eating versus what their visitors may be eating of what we have served them. To take note of when the patients eat. You know, some of us are grazers. We like to nibble during the day versus 3 meals a day. And you have better tissue synthesis when you consume 3 meals a day with a sufficient amount of protein, 25 to 30 grams of protein at a time, because it takes that much protein to reach that leucine threshold that triggers the mTOR pathway that starts tissue synthesis. So a 3-meal-a-day person may have better wound healing than the grazer that just nibbles through the day. To work with the RDN on nutrition-focused physical assessment, some of the RDNs are very skilled in doing this, others are not, and we may use some of our other medical team members to help with assessment for fluid retention and for using the dynamometer. And then lastly, to alert the RDN of a change in wound healing. If you have a wound that is stalling, if you have a wound that is getting worse, alert the RDN because it may be time for a change in strategy. We've talked about adding a lot of nutrition to our patients' diets, a lot of protein, a lot of energy, but is it cost effective? I think that's a question that all healthcare settings are looking at. The cost effectiveness of nutrition support, especially for prevention of pressure injuries. A year-long study was published in 2016 that was done in Australia comparing the standard care with nutrition support care. So the nutrition support care had a higher level of care, which included patient education, nutrition goal setting, and consumption of high-protein supplements. They did a very elaborate mathematical model and really looked at the economies, and they found that nutrition support care provided substantial cost savings, and the probability of nutrition support being cost-effective was 87%. And so this shows very clearly that there is value in providing nutrition support for individuals, especially if they're malnourished and at risk for a pressure injury, to prevent that from happening. But what about these disease-specific oral nutritional supplements? That would be such as the one that we talked about that contains the arginine and the micronutrients. Well, this was another study that CEDRA did and looked at the cost-effectiveness of a disease-specific therapy versus the isocaloric, isonitrogenous intervention, that's standard oral nutrition supplement or the house supplement, and demonstrated that the disease-specific oral nutritional formula improves injury healing, pressure injury healing. Now, it's important to note that the disease-specific formula was more expensive than the standard product, but using it led to significant reduction in direct cost for pressure injury-related care. And so it was a cost-effective recommendation. So what are some of the nutrition practice pearls to consider? First of all, if a wound is healing and the weight is stable and there are no signs or symptoms of dehydration, then what does that mean? Well, it probably means that protein, energy, and fluid or water needs are most likely being met. If you have a person with dietary restrictions and they're not eating very well, then this is a time for the medical team to really discuss the options of whether we can modify or liberalize some of these restrictions to try and increase food or water intake. Now, enteral feeding may or may not be recommended for patients, especially for older patients with advanced dementia. And again, this becomes what is the patient's goals, what are the family goals, and we've seen some studies that have showed increased complications and development of new pressure injuries with enteral feeding in this population, older adults with advanced dementia. There's some other studies that show just the opposite. And so, again, enteral feeding is an option, but we do need to consider all of the ramifications of that. And then our end-of-life decisions regarding interventions for treatment of pressure injuries need to be implemented in accordance with the patient's wishes and the overall health status and prognosis. The National Pressure Ulcer Advisory Panel has a number of resources available at its website, and one of those are pressure injury prevention points, and these are the ones on nutrition. Consider hospitalized patients as at risk for undernutrition and malnutrition from their illness or as NPO for diagnostic testing. You may be in good nutritional status before you had that accident or before you had that surgery, but if we do consider that these hospitalized patients are all going to be at risk for undernutrition, then I think we will be more alert to those that truly are and truly have malnutrition. It is important to use a valid and reliable screening tool to determine the risk for malnutrition, such as the mini nutritional assessment, and I mentioned some others earlier, to refer all individuals at risk of pressure injury from malnutrition to the RDN, to assist the individual at meal times to increase oral intake, to encourage individuals at risk of a pressure injury to consume adequate fluids or water and a balanced diet, to assess weight changes over time, to assess the adequacy of oral, enteral, and parenteral intake, to provide nutritional supplements between meals and with oral medications unless it's contraindicated. Today we've talked about a wide range of strategies to optimize nutrition care for your patients. I want you to think about the opportunities for changing the future of nutrition care services where you work. So what do you want to optimize? Is it the way that nursing, medicine, and nutrition care services communicate with each other? Could you streamline the process of writing diet orders and changing orders? What about orders for vitamin mineral supplements? What about orders for oral nutritional supplements? What about the tools you're using to screen new admissions for malnutrition? Is it something that was developed in-house that hasn't been validated, and there are validated tools out there that you could use? What about the nurse's use of the nutrition screening tools? When you look at some of the risk assessment tools, such as the Braden tool, it has a nutrition subscore. Is the nutrition subscore consistent with what the nutrition screening tool tells you? Sometimes it is, sometimes it's not. What about the way the nutrition screening tool scores are disseminated to other healthcare professionals? Is that information populated in the electronic health record, or does it kind of end up in the dead letter box, and so nobody seems to know what the score is? It was put in, but it's either not disseminated to healthcare professionals or it's in a place people don't know where to look. And then the way decisions are made on which fortified foods and oral nutritional supplements are stocked. This is just a short list of ways that you can optimize nutrition care for your patients, but I hope today that this has given you some food for thought of ways that we can use nutrition to prevent pressure injuries and to prevent loss of lean body mass. This concludes my presentation. Thank you so much for joining us, and thank you to our sponsors. The program has been provided by the North America Center for Continuing Medical Education and is supported by an educational grant from Abbott Nutrition.